Sandifer syndrome is kids who have a sort of extensive posture and turn their head to their side, and they can look like they're having a seizure, but it's a sort of more of an extreme response to reflux. We do know that babies who reflux have an increased risk of respiratory symptoms. And as I alluded to in the Alti, that there can be this reflex apnea in young infants when they get acid reflux even into their lower esophagus. They can reflexly apnea. There are activation of respiratory receptors associated with airway hyperresponsiveness in infants that reflux. If you're getting a child who's spilly and wheezy, then you need to consider microaspiration. So this is where you get small amounts of milk which can get down into the airway and irritate and so cause cough and wheeze. We then think if they got anything anatomical wrong with their vocal cords or their larynx. Or things like an H fistula. You can have a little fistula between your gullet and your trachea. And so when you swallow your milk, then some of the milk can get across through this fistula into the trachea and so cause a reflex cough and wheeze. So we would do a barium swallow to look for that, or get the ENT people to review a baby, like the larynx and the vocal cords. Sometimes they can just do that in clinic with a little endoscope, but if they really want to ensure that the child doesn't have something rare like a laryngeal cleft, which is an abnormally formed posterior aspect to the larynx, which allows a bit of milk to track down and get into the upper trachea. There's also, we from time to time diagnose what we call vascular rings, which are an aberrant vessel, often a subclavian artery, which comes off in a different angle and then can wrap around the esophagus and the trachea, and they can associate spilling and wheeziness. So, and often we can see that on a barium swallow. You see a little indentation in the esophagus from this vascular ring. So just there are a number of relatively rare things. So we do find, organic disease in spilly, unusual diagnoses in spilly or wheezy babies. So just to say that there can be other causes for spilling, not just the gastroesophageal reflux. So looking for other symptoms like the baby's coughing a lot or wheezing with feeds is a red flag for us to think of some other anatomical problem. And I just reiterate again, beware the green vomit, and that's sort of a medical emergency. If you get rung, at 10 o'clock at night saying, a 2-week-old baby's had a green vomit, they should be coming to hospital that night, not wait till the next day. Projectile vomiting, so that implies there's more force behind the vomit. So, and basically, if you rule of thumb, if the baby's in a cot and the vomit comes out of the cot, it's got to go more than a foot or so. So it's that sense of forceful nature to the vomiting. The classical cause of projectile vomiting is pyloric stenosis, which, do you know when does that normally present? How old are?
First few days.
Well, that's a pyloric stenosis more in 6 weeks, because it's the pylorus is the outlet of the stomach, and it's surrounded in smooth muscle, and over a number of weeks, the smooth muscle slowly hypertrophies and gets thicker, and it causes an outlet obstruction to the stomach. So then the stomach is having to more forcefully contract to try and get the milk out of the stomach, and so then you get this increasing forcefulness of your vomiting. So you know, you guys will be seeing babies who are developing pyloric stenosis. So it's just to be aware of that history, that they can just start off occasionally spilling, but then they just start to spill more often, and their vomiting or spilling becomes more forceful. And as soon as it gets that projectile, real forceful nature to it, that's when you really need to be considering. It happens over a number of, often weeks rather than days. It's classically around that sort of 6-week age. It can be a sign of raised intracranial pressure as well, which can be due to like a head injury or, you know, a subdural hematoma. Would, you know, a younger, like a 3-month infant who comes in with projectile vomiting, that'd be part of your differential. You can get projectile vomiting with things like meningitis or, you know, severe bacterial illness, or you know, obstruction, bowel obstruction, but it's the real projectile nature to it tends to be either raised intracranial pressure or this pyloric stenosis. Which the pyloric stenosis is relatively easily treated. They just basically divide the hypertrophy, with a scalpel, just cut through, or a laparoscope, cut through the hypertrophied muscle and sort of opens it up, and then that's usually it. Occasionally they can reform, but very, very rarely. If you get blood in the streaking of blood in the spill, that can be the Mallory-Weiss tear is just where the little sort of vessels in the lower esophagus, they can rupture just from the forceful nature of the vomiting. And anyone who's had like a gastroenteritis, and you just sort of vomit, and then you can see a little bit of streaking of blood. So that's just related to the forceful nature. You can get some bleeding from ulceration from the acid reflux. So again, if there's any suggestion of any sort of blood in the vomitus, we'd usually then start on an antacid like ranitidine or omeprazole. If you've got a spilly unsettled baby who's got an altered bowel habit, that's when I would consider the cow milk protein allergy as well, or malabsorption. And again, that's, if you're considering malabsorption, looking back at your growth chart, and you know, they'd need to be seen quite urgently if the infant was, you know, crossing centiles or not gaining weight appropriately. We talked about abdominal distension, and the vomiting after 6 months. So just again, that natural history, you know, that gastroesophageal reflux should be getting better by 6 months, not starting or getting worse. So if you're getting reflux, so you can get ulceration, bleeding, and eventually you can get sort of stricture or narrowing of the esophagus, which can be a long-term problem, and the concept of this Barrett's esophagus of a lifetime increased risk of adenocarcinoma with untreated severe persistent gastroesophageal reflux. There's this sort of interesting condition which we're still getting to the bottom of understanding its sort of pathophysiology and treatment, eosinophilic esophagitis. And so it's often a spilly atopic infant who their spilling doesn't get better and persists beyond a year of age, and they can develop this dysphagia or discomfort with swallowing or eating. And when they have a biopsy, it's the inflammation is predominantly eosinophils, and it's felt to have an allergic causation. And we can try different alterations in the diet, removing either cow milk, soy, or wheat, or sometimes we use swallowed fluticasone. So that's the asthma inhaler, but they take it directly in their mouth and then swallow it, and so it acts as an anti-inflammatory in the lining of the gut. And there's some suggestion if this goes untreated that they can get, again, strictures and narrowing in their esophagus in the long term. They can get these sort of furrows in their esophagus if left untreated in the long term. So again, we would tend to think of the possibility of this if you've got a baby who's still spilling when they're over a year, over 12 months, and they've got this sort of atopic sort of history to go with it. So if the investigations are really determined by history and examination. If you've just got an otherwise well infant who's spilling all the time, but they're growing well and they're otherwise healthy, we wouldn't do too much about it. We'll occasionally run some bloods, check there's not a low-grade urine infection, or get their stool looked at. But if just as if they're not growing well, if they're growing well, we don't tend to do much at all. But the investigations are very much determined by history and examination. As I've sort of alluded to, we need to sometimes look at the anatomy of the swallow if they've got respiratory symptoms such as feed-related coughing or frequent or persisting wheezing. The barium swallow, that's when they have a bottle containing some barium and they just watch it under fluoroscopy as it goes down. That's really just to look at the anatomy. It doesn't diagnose reflux as such. So you're just excluding an anatomical problem, particularly things like malrotation, because you can see that the outlet of the stomach and the first part of the duodenum is normally situated. So we don't use it to diagnose reflux, we use it to exclude anatomical problems. We can certainly do these pH probes, which basically is a probe which sits in the lower part of the esophagus and continuously measures the pH or acidity in the esophagus. And it looks at the number and duration of periods of the acid reflux into the lower esophagus. And there's also an event monitor too. So if a baby has some apparent pain, then you can hit a button and then you can try and see whether some of the behavior is associated with the reflux. Because if we've got an unsettled crying baby or a baby who's having respiratory events like apneas, and we want to try and determine what the cause of it is, then we can use these pH studies and then with an event marker on it. And since they've been doing these pH probes, they've found that actually babies reflux a lot. And the upper limit of normal is determined by the duration of the episodes, and the number of episodes more than 5 minutes duration, and the sort of reflux index, which is the percentage of time with a lower pH.
Sorry, can you just tell us how you're and how they put those probes in and how you read them?
There you go. So it looks like a nasogastric tube, basically, that they swallow, and it just goes down and just sits, there's the stomach there, and it just sits in that, because you shouldn't, in theory, you shouldn't be getting, lots of acid coming up and down here. So it's basically just measuring the acidity in that lower esophagus. So you usually have to get a chest x-ray just to check where it is, and you need to make sure it's above the diaphragm, that it's not actually sitting in the stomach, otherwise it's going to be acid all the time. And it basically stays in for the 24 hours and measures it continuously, and then we get a readout like that. So these are reflux events where you can see the pH dropping every time there's a reflux event, and so the sort of software counts up the number of the time spent under that pH, how many reflux events there are, the duration, and then the percentage of time. But you can see babies do reflux a lot, and so it's not, it's a common phenomena, and it's what we're trying to do is determine the more severe end of the spectrum, or are the symptoms that the baby is having because of the reflux, and that we need to go on and do more definitive treatment. Unfortunately, sometimes, particularly after a feed, that it may not be that acidic. So you can have reflux events where the pH probe may miss it. So there's actually an impedance probe now, which can actually just measure movement rather than just pH, because of there can be you may miss some reflux events if you're just measuring the pH. So how do we manage reflux babies? So most of the time, you know, if you're happy with the baby's thriving, they're not too unsettled, you know, you've taken your good history and examined the infant, they basically need reassurance. Again, talk about the natural history, upright positioning. You can try some thickened formula. If you look at the evidence, it's not terrific around, you know, it being particularly useful, but there are these pre-thickened formulas, anti-reflux formulas, which have basically modified cornstarch. Make sure that the baby isn't overfeeding, because that can be, you know, if you get an unsettled baby who's crying a lot, there can be the tendency to overfeed the infant too, which they can spill because they're just overfeeding in response to being unsettled. So, and those babies often tend to be the ones that are, you know, growing well, not excessively, but they're gaining weight, you know, faster than their other growth parameters. So, if that's the case, then you may need to talk about other ways to try and soothe the baby rather than to be feeding it continuously. Taking your history around whether there could be a subgroup of spilly infants, and I not infrequently see infants that get sent to outpatients. They're spilly, grumpy, scratchy babies, which can have slightly loose poos and a bit of eczema, and you put them onto these hypoallergenic formulas, and you know, you see them in the next clinic, and the baby is a new baby. You know, they're a lot more settled, and so there is a subgroup where they're sensitized to the cow milk protein and using either Pepti Junior, which is where the protein is broken down into peptides, which is smaller segments, or Neocate, which is where the I shouldn't be using brand names, but the is Elicon as well. I mean Elicare, the amino acids, which are the building blocks of the protein, but these amino acid formulas are very expensive, so PHARMAC usually requires us to try Pepti Junior or its equivalent first before we go on to trying an amino acid based formula.
So babies that were on a formula?
Yeah.
What was the research on that?
Well, you can advise to stop dairy first, try stopping dairy, and it needs to be exclusively dairy-free. They need to look at alternative calcium sources as well, so they could try like rice milk or something like that.
What about gut flora? Like, do you look at the baby's possible unbalanced gut flora from maybe antibiotic use or things like that?
If it was, if you had something like altered bowel habit, you could consider that. Right? Yeah, that's right. You can, and there's a lot of work being done on probiotics, and we're still sort of finding our way on, you know, what is the place of probiotics in young infants. There's a lot of work being done on whether it could be, helpful in preventing allergies, food allergies, eczema, asthma, and there is some preliminary work suggesting it can be helpful in preventing some of these atopic conditions. But there are lots of different types of probiotic, and there's different types, different strengths. When do you start it? Do you start it when the mum is pregnant, if there's a family history? Do you start it as soon as the baby's born? Do you wait until they've got symptoms? So there's a lot of unknowns. So there's potentially we'll understand, you know, the place of probiotics a lot more. But if you've got an infant who's, as you pointed out, who might have been on a course of antibiotics and then had an upset, you know, bowel pattern, I think that would be not unreasonable at all to...
Or even the use, I mean, when women are labouring and they're GBS positive, they're given antibiotics intravenously, which can affect the mother's gut flora and the baby.
Yeah, well, that's right, and there's exactly, there's an increasing amount of work being done on the microbiome, you know, just, you know, and as I say, it's definitely I think we're going to have a lot better understanding in the next few years about and then to be able to make more informed recommendations. I think it's just a little bit early to be making a lot of recommendations about that, but it's an area which has been studied in a lot of detail, and it's a sort of watch this space, so there could potentially be a number of indications. There are some antacids that people try, Mylanta or Gaviscon, but you do need to be aware that there's things like aluminium in Mylanta and various salts, which, you know, giving babies these, you know, for weeks or months on end, there might be, you know, is there some implication for that? So I don't normally recommend long-term use of antacids, but it can be used in the short term for some symptom relief, but I wouldn't be recommending its, you know, use in the long term.
What would you say was talking about, just thinking about the amount of Gaviscon given to babies?
Well, it's hard to be definitive about that, but I would say using occasional doses is fine, but I wouldn't say you should be giving it regularly for, you know, weeks on end. Because then I think if they're having persisting symptoms, then you need to be looking for alternative, you know, what are you treating in the first place? Are you, you know, are you sure that you're treating reflux? And if they're not responding to it, then I would be looking at other alternative treatments. If you really thought they had reflux, then we would be considering, you know, ranitidine or omeprazole treatment, or I mean, if you're just after the thickening effect of the Gaviscon, then I would just suggest a thickener rather than, you know, having the other antacid qualities. We, in the infants who are, particularly ones who are failing to thrive, who are very spilly, we can try some prokinetic agents and erythromycin or domperidone has been used. There has been, with erythromycin, there is a slight increased risk of getting pyloric stenosis because it can hypertrophy the pylorus. So there has been some association, but because it has this sort of, when we say prokinetic, it's sort of increasing the forcefulness of the gastric contraction, so that it helps the stomach emptying to try and reduce the amount of reflux. Maxilone metoclopramide has been used, but it's limited by its side effects. And cisapride we used to use a lot of, but that's been removed a number of years ago, so we don't utilise that anymore. And a relatively small number of kids need fundoplication, and they're children who have recurrent apparent life-threatening events or having recurrent apneic events. The infants who, you know, are neurologically impaired for whatever reason, they're at risk of aspiration, and they've got this increased risk of reflux. And basically a fundoplication, and they can be done laparoscopically. Basically it's a wrap around the top of the stomach is wrapped around the lower end of the esophagus, basically stitched together. So it just tightens the inlet to the stomach to try and reduce the reflux. They can, and depends a bit on how tight they make it, because you can't make it too tight so you can't swallow, but you want to make it tight enough so that you can't, you know, reflux or vomit up. So there's a bit of skill involved in getting the tightness of the wrap, and it can have some effect on the gastric emptying. And we do sometimes do that, particularly in the kids with neurological problems or other anatomical issues. They may need a gastrostomy tube, so they have a feeding peg in and a gastrostomy and a fundoplication at the same time. But obviously these are we use these when there's real medical complications related to the reflux. So I mean this is pretty rare, but it's you know what we work through in the possibility of the need for treatment of the severe end of the reflux spectrum. Is there any questions on the reflux?
Just never ceases to amaze me how you can have a baby that apparently spills half its feed every feed, and yet it's growing really well.
That's right. So that's what I always point out to the parents. Just go back to your growth chart and just say, oh, look, you know, however much the baby's spilling, it's getting enough in to grow well.
Yeah, that's where the growth charts are really, really useful.
Yeah, exactly. So you know, every time you meet a baby, you need to measure and plot them, and you know, and beware the infant centiles that are crossing the centiles.
I think we shouldn't also underestimate, and you hit on it with the putting social support in, and Philip did that shaking baby prevention program, and it's at peak crying where it's peak shaking the baby.
Yeah.
And so I guess as midwives us out in the community, I mean, I'm finding it their 2 week, 3 week, that's when I'll bring that conversation back up. It's brought up in pre-discharge, but it's not really relevant when you've just got your brand new baby. Yeah. It is when you've been holding a baby for 5 hours and it's not stopping crying. So, and I guess that goes on to GPs as well afterwards, too, when we hand over at 6 weeks, is just to follow on that message, because there is nothing more heartbreaking than a baby you can't soothe. And if you're alone, it's learning to lay your baby down, step away, take a breath, you know, what strategies if you haven't actually got support around you, that you can just support yourself to prevent anything happening by just shaking your baby out of frustration.
And it's, I mean, that's, you know, you couldn't have picked a worse time to remove the midwife from, you know, from the support, because that's some, you know, that's, but it, you know, right at the peak of their crying time is when, you know, in theory, you're not, you know, someone, you know, someone who's formed a relationship with the family, and then just right at when the baby's at its most unsettled, you know, say, well, you know, bye, we can't see you anymore. And often a lot of the other family members are all around, you know, that initial, you know, post-delivery phase and popping in, you know, meals and helping out. But 6 weeks, people are getting, you know, to sort of forget about the new baby, and it's just when they need, you know, even more support around that time. And the other partner's gone back to work, and you've got the primary caregiver who's left with a baby who's crying.
And you're 6 weeks into sleep deprivation as well.
That's right.
You know, so you're already running on low reserve, so yeah, it's not ideal.
I think often with the crying stuff, sometimes the breastfeeding problems that can cause that can be forgotten. It can often be quite simple things that somebody skillful can fix with breastfeeding, just in terms of position or in terms of giving too much of the, you know, not so much of the fatty rubbing against your tummy, or, you know, all sorts of different things that can sometimes improve unsettled babies a lot.
No, that's right. I think that's why taking your feeding history is very important, and looking at the growth pattern and how the baby sort of latching on. Yeah, that's right.
I wanted to ask, my grandson had extremely bad reflux, and he's 6 now, and he's a skinny little dude with very funny habits, like for eating. And I'm wondering about like permanent damage. I mean, I know body repairs with good care, but what's the thought on permanent sort of burning sort of trauma?
Well, usually not. I mean, that eosinophilic esophagitis I'd always, you know, consider that if you know, if someone has persisting symptoms, because you shouldn't, if it's just straightforward mechanical gastroesophageal reflux. The vast majority of infants, if they've, you know, that they've been, you know, thriving that they shouldn't have any long-term problems. And it's normally more the ones where their symptoms persist beyond that 12 months of age that we start to, but it's about the severity of the symptoms, their growth, and the persistence of it. So, but yeah, I would think about something like, you know, eosinophilic esophagitis if someone had persisting symptoms. Some babies are they have very sensitive pharynxes, and they tend to gag a lot on solids and can spill or vomit. They're just hypersensitive with their swallow. So we see a number of kids like that, or babies equally who get oral aversion, and we wonder whether they've had reflux, which then they've developed this association between feeding and discomfort. So then they can be just really hard to feed, and they just won't feed, and you know, we see a number of infants who even need to be nasogastrically fed because they just won't eat or drink enough for them to grow on. And we go through all these investigations looking at anatomical, but often we don't find any cause, and they just have this oral aversion, which, you know, it may be something that just triggers it off to begin with, but then it becomes a persisting behaviour which can be very difficult to manage, and it's not infrequent.
Is there any increased likelihood of gastric reflux of a previous baby, of a woman's had that condition?
Well, it's a wee bit hard to know because often we don't. They're not investigated. Like we don't do that many pH probes because it's reasonably invasive. So I think there's a little bit of expectation. So if the first infant was spilly and unsettled, with the next baby that comes along, first time it spills, they're down to the GP and want a script for omeprazole. So they can sometimes be that. I mean, it's sometimes because they've gone through, you know, putting up with a very difficult, unsettled baby for many months with the first infant, and they don't want to go through that again with the second. So I don't think there's necessarily that, you know, risk family for reflux, but they're more likely to present for management or treatment.
So is a good baby being prescribed with omeprazole?
Yeah.
How do you think about that?
Well, I think you need to go back to, you know, you indicate what are you prescribing it for, and because there are some potential side effects, and there is some associations with getting increased risk of respiratory illnesses as well, and respiratory infections, and so it's not without its potential problems. So, like any medicine, you know, you've got to be thinking about your risks and benefits. So I think you need to be asking why are you prescribing it, and so I would only usually prescribe it in the instances of, you know, a baby who was very unsettled, it was starting to issues with its weight gain, and seemed to be, you know, getting that feed-associated discomfort, and getting some aversion to feeding because of that apparent discomfort. But I wouldn't be, you know, just a happy, well-growing baby who's spilly. Some of those babies end up on omeprazole, but it's not going to stop the spilling. It's the other thing. It's just stops the acidity, so it's not going to alter the spilling.
Is that because of the bacterial contaminated universal microaspirations?
No, they don't get microaspirations, but that's an epidemiological sort of association. We don't, not sure exactly
The question was, what's the association with increased respiratory infections with reflux?
With omeprazole, with the use of omeprazole. So it's not, there are potential problems or side effects from the omeprazole. So
if they've got a milk intolerance, if you diagnose an intolerance to dairy with a child, what would you expect the poo to be like?
Well, it's not invariably. You don't always get alteration in the bowel habit, but that's another potential sign that there may be an intolerance there, because you may get either loose stools or even constipation there are a number of kids who have camel protein intolerance, particularly older, toddlers, that they get constipation associated with camel protein intolerance. So it's symptom alteration in your bowel habit, as in loose poos or constipation, and other, signs of atopy, like your eczema or spilling and irritability, and not gaining weight adequately.
Would you see blood in the stool sometimes with that as well?
Not invariably, no. There is the proctitis, which often babies present within around sort of 6 weeks, where they get sort of blood tinge to their poos, and that's not that uncommon. But those babies are very well in themselves, so that by definition, if you think it's an allergic proctitis, they're a well infant who doesn't have abdominal distension. They might just have a few stools with blood streaking. In fact, that's more common in breastfed infants than in formula-fed infants. And we sort of advise that if they're breastfed, they should try a go dairy-free, and then plus or minus soy or wheat-free if that doesn't help. But I've always thought that it's slightly unusual that it's more common in breastfed infants. You'd think if it was driven by camel protein, it would be more common in formula-fed infants. So, but that is a phenomenon we see not uncommonly. But they're a very well infant who might just get a slightly looser poo, and that's that fresh streaking of blood. But if you have a look in, the rectum and it's a proctitis. It's just a localized inflammation, which normally settles down within a number of days or weeks.
So you could see if it's settled down by cutting out dairy and
Yeah. So we would often consider, if they're on formula, going on to Pepti Junior, or advising a shorter term removal of dairy from the maternal diet of the breastfed.